Welcome, welcome, welcome. Thank you for joining us today for the February 1st, 2023 International Myeloma Foundation's Regional Community Workshop for the Northeast and Southern states. Many people have registered for this, so let's keep going. We put this program on, there's 10 of them a year, and I've done this for almost 20 years, and I've watched a lot of changes come through. So what I'd like you to be aware of, after you get through our workshop, you're going to probably have lots of questions, and you're going to say, maybe I missed something, or maybe I didn't hear what they said. You can always go back to the link that we're going to send you after your review of the topics today, and you'll get that in a survey as well. These will be provided to you and are important to you while you're doing some weightlifting in myeloma. Next slide. Well, we couldn't do this without our sponsors, and it's AbbVie, Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Sanofi, and Takeda. Without their generous support, this program would not be happening. And they support all the RCWs. And I'm very grateful as an employee of the International Myeloma Foundation. I'm very grateful that they help us help you. Well, we want you to participate. So while you're listening there and you broke your pencil lead and you can't get any further with it, just remember, this is a participatory program. We want you to ask questions and we'll try to get you the answers. But as you see here on the page, it says what to do. It says anonymously, or you can use your first name, but please do participate in this. This is where a lot of interesting topics start, and it makes a big difference. So, well, there's the arrow. See, you can do that and so forth. But something that's even more important to us is the feedback survey. We get this and we listen and we write down and we take notes and we talk amongst ourselves on how to make it better and how to do it better and why it's got to be better. So please feel free to handle the feedback survey after your program today. Gosh, that was hard to get out. Let's go on to the agenda. This one's not too hard. My name's Kelly Cox. I've been talking about you not knowing who I am, and I'm Senior Director of Regional Community Workshops. I put these programs on for the past 20 years, and they just get more and more interesting and more intimate as it relates to your progress in your myeloma. The next person, Craig Cole, I've known Craig since he was 4.5 years old. I'm kidding. He's going to do Myeloma 101 and Frontline therapy. Then we're going to get questions and answers with the panel. And then after that, we go into guided meditation and stretch break. Really want you to participate in this. Then we go into relapse therapy and clinical trials with David Vesole, another good friend. You'll like his talk. And then Kimberly Noonan comes on, and she will talk about life is a canvas and you are the artist. How bad is that? You're going to have a good time today. Sit back, get your paper ready and your notepad ready, and let's start this program. Myeloma 101 and Frontline Therapy, Craig Cole, Michigan State University.
Oh, thanks so much, Kelly, and thanks to the IMF for organizing these meetings, which help to empower patients. And really, it makes my job so much easier when patients learn and understand about the disease, and really, learn the good news of how we're making breakthroughs with myeloma in the way of research every day. And that's really what I'm going to share, is a lot of work that's been done over the decades to really make frontline therapy better and better. So we'll talk a bit about how common myeloma is. We'll talk about the different plasma cell disorders. We'll talk about how we get to the diagnosis of myeloma and the labs, because myeloma is very lab-based. And so learning your labs is really important. Then we'll talk about staging and risk stratification myeloma. Then we'll talk a bit about how these therapies work, which is really, again, the breakthroughs that have happened in myeloma is with a lot of the medications that we use. We'll talk about upfront strategies, about bone support, talk a little bit about the old stuff that is now the new stuff for drug induction therapy, and then perspectives. So inside the bone marrow, inside the squishy stuff in the bone, there live plasma cells. And those plasma cells make antibodies, which are part of our immune system, which are our proteins that attack bacteria and other infections. But those plasma cells, just like any other cell in the body, if they become mutated and they become cancer cells, those normal plasma cells that become mutated are now multiple myeloma cells or myeloma cells. And when those cells are mutated, they produce excessive amounts of protein in the bloodstream, which are called monoclonal proteins. We'll talk about that in a little bit. And that's how we frequently detect and monitor myeloma, is from those excessive proteins that drown out the normal immune system in patients. Because those mutated plasma cells, those myeloma cells, live in the bone marrow, they will squish out the normal production of blood that happens in the bone marrow, causing low blood counts, and specifically causing low red blood count, which we call anemia. Those plasma cells, they really thrive in the bone marrow space and actually cause destruction of the bone. And when they cause destruction of the bone, they can make the bones weak, which can cause bone fractures. And when they cause destruction of the bone, it also releases calcium in the bloodstream, which can cause high calcium levels, which can cause confusion, weight loss, and fatigue. And then that protein we talked about, that monoclonal protein produced by those mutated plasma cells, can get stuck in the kidneys, which is the filter of the body. It clogs up the filter, causing kidney damage, which is another way that we can look for myeloma. And so some of those signs and symptoms of myeloma, we use a mnemonic called CRAB, C meaning the high calcium level, R meaning renal or kidney failure, A meaning anemia, and B being the bone disease. Again, some of those symptoms of myeloma, the low blood counts and those myeloma cells are pushing out the normal cells, happens in a little over half of patients when they present with myeloma, and that can lead to, and those low red blood counts can lead to weakness and fatigue. Also, when the extra blood protein clogs up the kidney, it can cause kidney failure. That's again about in half of patients, again causing weakness and fatigue. Again, it can cause bone destruction and bone damage, leading to fractures in patients, which can lead to pain and weakness and fatigue. And then finally, as we mentioned, it can lead to high levels of calcium when the myeloma cells are causing that bone damage. And high levels of calcium can cause appetite, weight loss, loss of appetite, weight loss, and again, fatigue. And we use the CRAB criteria, or the CRAB, as a mnemonic to remind us about those presenting signs and symptoms of the disease. Although 10 to 20% of patients with myeloma will be diagnosed by someone checking the blood, by checking that extra protein level, or having mild anemia, and they can be discovered to have something called smoldering myeloma or asymptomatic myeloma. Some of the fast facts about myeloma, it's the second most common blood cancer behind the lymphoma or lymph node cancers. About 35,000 people are estimated to develop myeloma this year, and the incidence slowly has been climbing over the past 20 years. Right now, a little over 140,000 people are living with myeloma right now. We'll get back to that fact. Myeloma is a cancer of adults. I'm no longer using older people as I get older. It's a disease of full-grown adults between the age of 65 and 70. And interestingly enough, the incidence is higher in Black people around the world, actually, not just African Americans, but people of African descent have twice the incidence of myeloma as compared to Caucasians, and 3 times the incidence compared to people of Asian descent. And why that discrepancy exists, we're not quite, a lot of research is going into, but we don't know quite yet. So the different types of plasma cell disorders, MGUS, so the monoclonal gammopathy of uncertain significance. What that means is that you have a little bit of that M protein, small amounts of M protein, small numbers of plasma cells in the bone marrow. The normal amount of plasma cells in the bone marrow is 1%. So if you have less than 10%, there's not a lot of plasma cells and no symptoms. That's a very common condition. About 5% of people over the age of 50 will have MGUS and has a low risk of progression to multiple myeloma, about 1% per year. Then there's smoldering myeloma. You have more plasma cells in the bone marrow, over 10%. And you have more protein produced by those more plasma cells, but again, have no signs or symptoms and none of those CRAB criteria that we talked about. That is a higher risk of turning into myeloma, about 10% per year. Then there's something we call high-risk smoldering myeloma, where the protein's higher, the amount of plasma cells are higher, and the hemoglobin continues to drift down, and the protein continues to go up. And when we see those dynamic features happening, then that's about a 50% risk of turning into myeloma in 2 years. So we carefully watch those people. And then we've talked about true myeloma is when they do a bone marrow biopsy and find more than 10% of plasma cells, and you have those CRAB criteria. And in about 2014, we recognized when patients had more than 60% of plasma cells in the marrow, or their free light chains that we'll talk about in a bit were very high, or if they had more than one lesion on a sensitive scan, like a PET scan or MRI, that they had an 80 to 90% chance of developing those CRAB symptoms in 2 years. So we actually started treating those patients. So again, MGUS, we usually observe or put people have people go on clinical trials. Smoldering myeloma, observation of clinical trials. There's a lot of discussion about treatment of high-risk smoldering. I think we need to do more research to really make sure if people benefit from doing that. The close observation of clinical trials, and then, of course, patients with true myeloma or slim CRAB myeloma, we treat those folks or have them enter clinical trials. So labs, we talked a bit about labs already. The CBC, super important test, because that tells us what the hemoglobin is, or the red blood count. So we know if someone is anemic. The comprehensive panel, the basic panel, which measures calcium, creatinine, which is the kidney function, and give us an idea about bone. The alkaline phosphatase is a chemical that's in bone, and gives us an extent of the disease. Again, those CRAB criteria are in between those two tests. Then there are two tests that we specifically use for staging, the beta-2 microglobulin and LDH. The beta-2 gives us another idea, besides the M protein, about how many plasma cells are in the body, and the LDH is a chemical that's released from cells when they divide quickly. And so higher levels of those tests kind of give us an idea of what the biology and how much myeloma there is in a particular person. And then there are the protein tests, and this tells us how much myeloma there is. The serum protein electrophoresis tells us how much. The immunofixation tells us the type, if it's IgG or IgA or kappa or lambda, and the free light chains help us tell about those free lights that we'll talk about in a minute. The urine tests, the 24-hour urine tests, usually we use those these days for research purposes, but we've been doing urine testing for myeloma since 1847. So let's talk about those protein tests, the serum protein electrophoresis. So normally, if you were to break down the different proteins in the blood, you'll see different types of protein. And one in particular, all the antibodies that people have normally are in that gamma region, or that the broad hump that is to the right. However, if someone has myeloma and those plasma cells are producing excessive amounts of protein, there'll be a tall spike that can tell us this is very different than that broad hump in the gamma region that I showed you earlier. And that's the monoclonal protein being produced by those malignant plasma cells. We do a bone marrow biopsy to count the number of plasma cells, and it should be pretty much equivalent to the amount of M protein any particular patient has. And it's important to know that because as we treat the myeloma with the treatments I'll talk about in a minute, and we reduce the amount of plasma cells, we don't want to have to repeat bone marrow biopsies over and over again. We can just do that lab test looking at that M protein. When we see that M protein going down, then we know it's time to celebrate that the treatment's really working and sustained in its working. Some patients will only produce light chains. The plasma cells will be so mutated, instead of producing that whole monoclonal protein, they'll produce just fragments of protein called light chains. And the light chains we measure with the free light chain test or the free light chain analysis. And usually we produce pretty low amounts of kappa and lambda light chains in our blood. So everyone produces low amounts of those proteins normally. And the ratio between the kappa and lambda should be about 1-to-1. However, if you have myeloma, one of those proteins, either kappa or lambda, will be very high, and the other one will be smushed down because those plasma cells are pushing those normal plasma cells away. And then the ratio between the two will be, instead of being 1-to-1, it'll be like 100-to-1. And that tells us, again, that someone has light chain myeloma. And again, with treatment, we reduce the number of plasma cells down, reduce that kappa light chain back to where it was, and then the lambda light chain comes back in, or vice versa if you have lambda light chain myeloma. And again, the ratio is 1 again, and then you know when to celebrate. And that's how we monitor and diagnose myeloma. Most patients, about 80% of myeloma patients, will have that intact protein. The SPEP will work for them, that monoclonal protein, IgG, kappa, or lambda, and those light chains will be stuck to those heavy chains. But again, about 18% of myeloma patients will only produce light chains, where those free light chain tests will be important. And then rarely patients will be non-secretory myeloma, where the myeloma has become so mutated, it doesn't produce any protein at all. So how we reach the diagnosis is that we also get x-rays. We've been doing x-rays for myeloma since 1900, and it will show punched out lesions or lytic lesions. And this was a patient of mine that, and you can see in her skull, she has multiple lytic lesions. Those didn't hurt her at all, but it was a very specific sign for myeloma. These days, we use PET scans, and PET scans are about 85% more sensitive than the x-rays that we've been doing to pick up other lesions that the x-rays may not be able to find. And then finally, we make the diagnosis by doing a bone marrow biopsy, and here's the enemy. Those are those plasma cells that are mutated, that are in the bone marrow. And if there are more than 10% plasma cells in the marrow, and patients may meet those CRAB or those slim CRAB criteria, that's when we know when to treat. So once we meet the diagnosis, then the question is what went wrong in those plasma cells in the first place? And then we look at the mutations that actually occurred in those myeloma cells. So when we do the bone marrow biopsy, we get those myeloma cells, and you look at the chromosomes, the DNA that's inside of them. And one very effective way to look at for mutations in myeloma is something called FISH testing, or fluorescent in situ hybridization, where it is a stain that goes on the plasma cells that paints specific chromosomes and can tell us, as in the patient that is in that black box, that they have 3 chromosomes and triples of chromosomes, which is the reason why this patient developed myeloma in the first place. We are getting more and more into doing genomic testing for myeloma, but our usual risk stratification for myeloma is with the FISH testing, looking at what mutations have taken place. And then we stratify patients into high risk or standard risk myeloma. There are specific mutations that can happen in high risk myeloma, where it's difficult for patients to maintain long-term responses with high risk myeloma. If those patients are missing the 17th chromosome, or they have extra copies of the first chromosome, or 2 chromosomes are stuck together, like chromosome 4 and 14, or 14 and 16, or 14, 20, or if we do genomic testing and find mutations in P53, those are high risk, harder to keep those patients in long-term responses. Most patients are standard risk, where they have triple chromosomes, like that little box I showed you, or translocations of 1114, or translocations of 614, which are pretty rare, or that the tests were just basically normal and no mutations were found by the FISH testing. So what do we do with all this information? Then we stage people. And stage one is when patients have a low beta-2 microglobulin, so a low amount of those little proteins on the myeloma cell. They have a normal LDH, so plasma cells aren't dividing so quickly, and no high-risk cytogenetics that we talked about, the 414, deletion 17, or multiple copies of chromosome 1. Stage 3 is when you have all those things, when you have high amounts of the beta-2 microglobulin, those cells are reproducing quickly, LDH is high, and you have high-risk cytogenetics. In stage 2 is when you don't fit cleanly into either one. Maybe the beta-2 is a bit higher than stage 1, but doesn't fit stage 3. So those are the 3 stages of myeloma. So now that we've diagnosed myeloma, we staged the myeloma, we talked about how common it is. So how do we treat multiple myeloma? And we use science to treat myeloma. We only use a little bit of chemotherapy once during the course of a patient when they're diagnosed, but we use science to treat myeloma. The immunomodulatory drugs that we'll talk about, and with Revlimid, the one that we usually use, an upfront therapy. The proteasome inhibitors, and we'll talk about how those drugs work, including Velcade, and then the antibodies against myeloma to get your own immune system to attack. And there has been a plethora of new drugs that have been approved by the FDA, including selinexor, ide-cel, and Citracel, the CAR T therapies. Teclistamab was just recently approved in October, and there are lots more drugs to come down the pipeline for myeloma. So how does the Revlimids and how do those immunomodulatory drugs work? Well, here's a plasma cell a little cartoon of a plasma cell. And again, how these drugs work is they use science. And so Revlimid and pomalidomide and thalidomide inhibit DNA synthesis to a very small degree. So it keeps the cells from reproducing to a small degree. And what they do in part is they inhibit blood vessel synthesis. So a chemical called VEGF is released by the vascular endothelial growth factor is released by the myeloma cells to try and get more blood vessels to feed the disease. And those IMiD drugs decrease the amount of VEGF and therefore starve the myeloma cells from their food supply in the way of blood vessels. That's just a small degree. What it does a lot of, and I mentioned it a couple times before, myeloma cells love the bone marrow compartment. They're really dependent upon that bone marrow microenvironment, and these drugs break that connection. Myeloma cells will only live about 3 or 4 days without being connected to the bone marrow stromal cells. If you break that connection, they will die. And also, they get fed. The reason that they love the bone marrow compartment is they get fed by those stromal cells, especially interleukin-6. And these drugs decrease the amount of interleukin-6 released by the bone marrow stromal cells, again, starving the myeloma cells. And after about 5 or 6 years of having these drugs around, we then found something incredible, that the IMiD drugs actually get your own T cells, the cancer-hunting cells that you naturally have, and it turns them to attack the myeloma. So your own immune system begins to attack the myeloma, which then gets rid of the disease. And so these IMiD drugs work on multiple modalities. It really is, I think, incredible how these drugs work. Thalidomide was the first that was out, had quite a few side effects. So subsequently, analogs were made that had less side effects or more potent. In 2006, lenalidomide or Revlimid came out, found to be 50 to 2,000 times more potent than thalidomide. Pomalidomide was even more potent than that. Iberdomide is now in late clinical trials, is the newest class in drug. And what is really, that we're really excited about are the CELMoDs, the designer IMiD drugs, which are more potent than any of the IMiDs that I just mentioned. We're really excited about the CELMoD drugs. So proteasome inhibitors, the drugs like Velcade and carfilzomib, how do they work? Well, inside those myeloma cells are little garbage disposal called proteasomes, because those myeloma cells produce tons of protein that need a good trash disposal system to get rid of a lot of those proteins. And so plasma cells are packed in and very dependent upon proteasomes, I'm sorry. And when those myeloma cells produce proteins, and then those proteins get worn out, they go to the proteasome, get chewed up, and then get disposed of out and excreted by the plasma cell. Again, plasma cells are very dependent upon that. So what if we could put cement in the garbage disposal of the myeloma cell, where now you can't flush the myeloma toilet? What happens is those proteins then build up inside the myeloma cell, and the myeloma cell pops open and kills the myeloma cell. It also breaks the connection to the bone marrow stromal cells and also starves them of their food supply. Pertuzumab also came out in about 2003, showed high activity in clinical trials. Carfilzomib is the second generation irreversible proteasome inhibitor. So it really damages the proteasome for forever inside the myeloma cell. Very high response rates. And then the oral version of bortezomib, Ninlaro, was approved in 2015. Then finally, the other drug that we use to treat myeloma these days are now, and they're really exciting and revolutionary therapy, are the surface antibodies for myeloma. So myeloma cells, just like every other cell in the body, has very specific proteins on its surface that helps identify it as myeloma cell. So every cell in the body has a license plate or has a identifier, and myeloma cells have specific identifiers. Some of them are called, one is called SLAM7, one is called GPRC5, one is called CD38, and then there's the BCMA surface protein. And what people have done is that researchers have developed immune therapies against those antibodies, against those proteins on myeloma cells. And specifically, the daratumumab and isatuximab were antibodies directed towards CD38, because myeloma patients aren't making antibodies against their own disease. So those antibodies are made in a laboratory to have your immune system attack it. And I'll show you that in a second. The immune therapies against BCMA include those CAR T therapies, and the bispecifics called teclistamab, and elotuzumab is against SLAM7. And there are more to come using those other surface proteins. So how do these immune therapies work? Well, there's a myeloma cell, and you can see those surface proteins, and in this case, CD38 on top of the myeloma cell. And then we either sub-Q or either under the skin or intravenously administer that anti-myeloma antibody, and your immune system will attack anything that has an antibody attached to it. So the natural killer cells will degranulate, shoot bullets at the myeloma cell to kill it. Also, when antibodies are attached to the myeloma cell, the macrophages attack the myeloma cell in hand-to-hand combat. So you got the artillery and the infantry going after the myeloma cells. Also, anything that has an antibody attached to it will activate an ancient part of our immune system called complement, which will bore holes in the myeloma cells. Also, when these antibodies attach to the myeloma cell, it actually short circuits the myeloma cell from within, killing the myeloma cells. And then finally, when those antibodies are attached to the myeloma cell, the bone marrow stromal cells will kick them out and get rid of them. Again, starving the myeloma cell of their food supply. So we have a lot of options for different drugs to treat myeloma. Again, the immunomodulatory drugs are the IMiDs, the proteasome inhibitors that we talked about. We do use chemotherapy, usually for Cytoxan if someone's kidney function can't tolerate some of the IMiDs. And we use melphalan for stem cell transplant. We still are very dependent upon steroids and dexamethasone to treat myeloma. And then we talked about the monoclonal antibodies and Darzalex specifically for upfront therapy for myeloma, which now gives us a number of different options of how we treat. And the usual treatment sequence is that we give an induction therapy, so something to immediately control the disease, to push down the disease initially, then a consolidation, and we recommend stem cell transplant, is we do the 1-2 punch I'll talk about in a second, and then we do maintenance therapy. So I tell my patients with myeloma that you'll be on, just like when patients have diabetes, they're on long-term maintenance therapy. When you have myeloma, you're on long-term maintenance therapy. And then when the disease comes back, then we have an open playbook of lots of different therapies, including some of those newer therapies that we use for relapsed myeloma. So for newly diagnosed myeloma, the first question we ask is someone a transplant candidate? And that is not based on age, but based on other comorbidities and other medical problems and how well you're getting along. Then the question is, are you high risk or standard risk? If you're high risk myeloma and you're not a transplant candidate, we'll frequently use daratumumab, an antibody, and Revlimid or RVD, the triple therapy. For standard risk, we would use the antibody and Revlimid or RVD light for about a year, and then we do a maintenance therapy. If someone's a transplant candidate and high risk, then they'll get a 4-drug induction therapy with either Dara-RVD or Dara-KRD with carfilzomib, early stem cell transplant followed by multiple drug maintenance therapy. In standard risk patients, again, our preference is for them to get RVD till the protein is reduced, then go to stem cell transplant and the maintenance therapy. This is the iceberg model for myeloma that I talk to my patients about, that when patients first come in, you can tell that they have myeloma because they have bone breaks, they have fatigue, they have kidney function problems, and they have over 1 trillion myeloma cells. And as we start the therapy, we reduce the myeloma down underneath the waves and reduce the disease down. We see that M protein going down. And when it goes down by half of its initial number, we call that a partial response. If it goes down by 90%, we call that a very good partial response. And then if the protein goes away, we'll call that a complete response, or sometimes we call that a complete remission. Although the myeloma will come back at some point, the deeper the response, the longer it takes to come back. And again, we try for those deeper responses, the deepest response that we can get with the therapy that we have. One way we get those deeper responses is that we use stem cell transplant. And what I I don't know much about boxing, I'll be honest, but my understanding is you know, when you're a boxer, you use that right hook over and over again, the Dara-RVD or the RVD therapy. And then when the myeloma is beginning to waver and they're getting weak in the knees, you deliver the left hook, which is stem cell transplant, that chemotherapy the disease is not expecting. And there's a study that recently looked at transplant versus no transplant for myeloma patients in the United States. So in this study, all patients got RVD for about 3 cycles. So they got a 3-drug induction regimen with Revlimid, Velcade, and dexamethasone. And everyone got stem cells collected, but half the patients got the stem cell transplant, the other half didn't. And they were randomized between. So everyone got good therapy, but one side of the patients got the stem cell transplant. Then they got consolidation, underwent maintenance therapy. And the question was did patients benefit from getting stem cell transplant? And the answer is the transplant versus no transplant in green, transplant in yellow, that when it comes to toxicities, yes, that there were more toxicities with getting that extra dose of chemotherapy. However, all those toxicities happen in the hospital. So if you have low blood counts and you have transfusion, happens in the hospital. You get nausea with the chemotherapy, happens in the hospital. And so, yes, the toxicities were higher, but also you see with the non-transplant people, there were actually some toxicities there too. The time it took to relapse. It took longer to relapse if you got a transplant if you didn't, because it pushed down the disease just that much deeper. And if you had high-risk myeloma, you really benefited from transplant. Again, when patients have high-risk myeloma, they don't stay in those remissions very long. Transplant did its job definitely for those folks. Overall survival was the same. So overall survival, because you have so many good therapies and the myeloma comes back, that the overall survival was the same. And how long, again, patients stayed in those deep responses was longer with transplant. And those really, really deep responses, the minimum residual disease, whereby molecular testing, we can't find any disease, longer with the patients that got stem cell transplant than those that didn't. So at a follow-up of 70 months of the determination trial, there's a 53% risk of progression or death in the RVD alone versus a transplant group. And that's why we recommend stem cell transplant for patients that are eligible for transplant. My patients have said, what about my quality of life? And this little graph shows you that the patients who got stem cell transplant, the quality of life, the transplant patients were in red, patients that didn't get transplant were in blue. And you see that for physical functioning and overall global health status, that there was a dip in their performance and how they felt when they got the transplant. But look, after they got through the transplant, they were back up to normal, to their non-transplanted colleagues, if not a little bit better. So yes, it's no fun getting a stem cell transplant. When you come out, the disease stays away longer and you're just as good as anybody else. So what do you do after transplant? There was a study that looked at that randomized patients between going straight to maintenance therapy after stem cell transplant versus consolidation or a second transplant. And that found that all the arms were equal. So usually what we do outside of clinical trials is that we have patients undergo a stem cell transplant. Sometimes we give them consolidation and sometimes they go straight to Revlimid maintenance therapy. With the high-risk patients, we have to think through a little bit. And then there have been multiple trials looking at the benefit of maintenance therapy long-term for myeloma patients. And there have been, again, improvements in the time it took to relapse by taking maintenance therapy than not. And the duration of maintenance therapy remains unknown. So right now, when patients, after they get transplant, or even if they don't elect a transplant, they go on maintenance therapy until they relapse. And bone support is really important because we have to heal the bones while we're taking care of the disease. And what we do for that to make the bone strong is use some of the bone strengthening agents. Pamidronate, which is the older drug, Zometa, the newer drug, and Xgeva, the newest drug, which are given monthly for 2 years to help strengthen the bones, along with taking vitamin D and calcium supplements to make those bones strong for patients to feel better and have less pain. The most recent thing that happened, and really the readout for this came at our meeting in Los Angeles in August, where we have been giving the 3-drug induction regimen for years, RVD. We've been doing that for almost a decade. And we added on DARA, and we did a randomized trial because we wanted to see, is this current standard of care, RVD, can you make that better by adding on that DARA, that antibody drug to get your immune system to attack the myeloma? So these patients were given RVD or DARA RVD, the addition of daratumumab. They all underwent stem cell transplant, got consolidation, underwent either DARA Rev maintenance, or they had Rev maintenance alone, which is the standard of care. So nobody got bad therapy. Everyone got good therapy. But what we found out, and look, this was amazing. The patients that got RVD, our current standard of care, 91% response rate. 91% response rate. And those deep responses, 73% of patients had very good partial responses or better. However, the patients that got the DARA RVD had a 99% response rate and even deeper responses at the end of consolidation. And then when you throw on at the end of the study, after they have been on maintenance therapy, look how much those responses were deeper. 96% of patients that got DARA RVD were in that very good 90%. The myeloma was gone, and which really helped us define the new standard of care. At least we're getting there. And with a 55% reduction of progression, not so much death, but more progression by using addition of daratumumab. And really, I think for drug therapy, induction therapy is where a lot of research, and the encouraging thing is look at all of these. It's a busy slide, but look at all of this, like response rates, 99, 100%, 99, 100%. Really, it is, things are happening very quickly in myeloma land. So it's important to know your goals of therapy. Do you want to reduce I had a patient who came in and says, I want to be MRD negative. I said, I can help you do that. We did a stem cell transplant and we did a 4-drug induction therapy. It's also important to know to read your M protein, because you have to know when to celebrate when a treatment works, because the amount of plasma cells in the bone marrow equals the amount of M protein. And again, as we treat, we get rid of the myeloma and the M protein goes down. Know your stage and risk, so you know what therapy you should undergo and the benefits of that therapy. Know when your response, so that you know, again, when to celebrate. And know the side effects and who to report them to. It's really important. If you have a side effect like a rash, who are you going to tell about the rash? But make sure you tell somebody, and always obtain a second opinion, because things change with myeloma so frequently. It's good to have a second opinion, another set of eyes to take a look at you. And then always think about clinical trials. The pointy end of all these great things I talked about are the fantastic patients that were involved in clinical trials. And this is helping me being more empowered and informed. This is my favorite slide, because with 4-drug induction therapy, now the response, when I started doing this, when I had hair, high top fade, and bell bottoms, I didn't have bell bottoms, but I did have parachute pants. But back then, we had a 30% response rate for myeloma, 30%. Now we're at 98% response rate. We've got 32 new drugs approved by the FDA in the past 10 years. With these novel drugs, now people are living much longer than they lived when I first started doing this. And when you look at how many people are alive with myeloma right now as compared to 2004, we now, again, have 140,000 people living with myeloma. In 2004, we only had 50,000. It's not because the incidence is going up that quickly. It's because people are surviving this disease, which is really, again, exciting. And so, yes, myeloma is not curable yet, but it's survivable now. Thank you. Oh, and that's our hospital and our lab at MSU. But thank you.
Bravo, Craig. And what a great presentation. I love the pictures. Now, is your lab in which building is your lab? Are you work both buildings?
The lab, I primarily work in the building to the left, and the lab is the one to the right.
That's fantastic.
Yeah, it looks pretty snowy right now, though, so it doesn't look like that right now.
Oh, is it gray?
It's pretty gray, yeah.
Not like your treatment, though. Your treatment's straight up, Craig, and I appreciate your presentation today. I think it's going to be helpful to some patients. Listen, we got a couple of questions there, not too many. One question is, easing drug treatment side effects. Is there a heavy view in that? Are they working that? Are they thinking about that?
You know, that's a super good question, because now when, we are now blessed with having so many new drugs coming down the pipeline for myeloma, now we can be choosy about choosing drugs that have less and less side effects. And so we have now, back in the thalidomide days when we had no options, we allowed patients to have terrible neuropathy, to be super fatigued and have lots of side effects. Now we have no tolerance for that because we have so many options. And so if there's a clinical trial that shows that a drug has lots of side effects, we'll say, go back and work on these side effects, or we work on those side effects as a group to try and minimize it. So there's a lot of research to try and minimize side effects from the drugs, for new drugs itself. And then there's a lot of research going on to see what's the best way to treat it. One thing was the diarrhea that's associated with Revlimid. And Faith Davies realized that there were patients that benefited from a cholesterol or drugs that help with the gallbladder and found that helped the diarrhea. And so we always are looking for ways to try and minimize the side effects while maximizing the benefits.
That's great. Another great question here. Well, they all say great presentation. We already know that.
Thank you.
Is CAR T an advance over DARA RVD for high risk smoldering multiple myeloma?
Ooh, well, there's a question for you. That's a controversial question. So we'll see. I mean, I think that is a definite research question. I did a talk actually on smoldering yesterday, and one of the things that, are those therapies very, very effective, and is CAR T more effective for plasma cell killing? It is very, very good at killing plasma cells. The trick with smoldering myeloma is that patients don't have any symptoms of the disease, and not everyone with smoldering will develop myeloma. So are the side effects greater with CAR T? They're different than CAR T. And one thing when we think about smoldering myeloma is we have to figure out, I think we need to figure out more of how the biology, how the science of smoldering works, how patients develop myeloma, and attacking it there, and coming up with specific therapies for smoldering, then recycling myeloma therapies for smoldering myeloma, because the two aren't necessarily the same.
That's fascinating. I hate saying this. I'm just going to turn to the info line. You guys, one person here said, my stem cell therapy only lasted 2 years. What's now? Craig, there's all sorts of things that could happen there, I presume.
Yeah, I mean, the one thing about myeloma is that it's really multiple myelomas, that everyone has a different disease. I don't have two patients that have had identical courses or on the exact same dose of every therapy. That different patients, I've had patients that have had very minimal treatment, that have been in responses for decades. And I've had patients who have relapsed very quickly. And some of that we can categorize based on risk. But sometimes that 1-2 punch doesn't work so well. And then what you do is you reach for some of those newer drugs, or you talk about clinical trials, the newest, the most pointy end of the myeloma armamentarium in clinical trials to get control over the disease. And there are specifically clinical trials for what we call functional high-risk patients, which are those that relapse soon after transplant.
I haven't seen this question before. Does the 4-drug treatment work well for kappa light chain myeloma?
Yes, it does. And so the light chain, the one trick about kappa light chain myeloma is that if it's causing kidney problems, that the 4-drug, that you have to watch the dose of the different therapies. But the patients that were on the Griffin trial also contained patients with a high-risk myeloma and patients that had light chain myeloma, and it worked for those folks too.
Gosh, that's great. And then we'll end it with this. Does the M spike disappear immediately after treatment?
So the M protein.
I'm sorry.
Yeah. So it'll go through those stages, and people will go through those stages at different rates. And so what I tell my patients is that it's not a race, that, we want to get to that greater than 90% response before you go to transplant. And so we want to see the protein going down. And I have patients that have had a 90% reduction in M protein in a month. I've had patients that it took 3 months to get there. Is there anything better or worse about getting there? As long as you get there, as long as I can get to a Taco Bell, I don't care how long I do care how long it takes. So I drive kind of quick. So that's a bad example. Never mind. But, but you want
you have a bell at your house, Craig?
I wish my wife's a dietitian, so there's no way we have a Taco Bell at our house.
I was just double checking. Well, Craig, again, that was just skillful, fantastic information. And everyone that was watching this, you get to go back to the website or our link. We're going to send you an email and go maybe a little slower, but I think Craig went just at the perfect pace. So thanks, Craig. I really appreciate that.
Thank you.
Now, we're going to go into a little break here where we do stretching and a little mindfulness. And this is by a person I work with, Kelly Sidorowicz. So take a second for yourself. Watch this, relax, and then we'll get into the third and fourth quarter. Thank you. Wow, I'm so relaxed. I feel like my shoulders are disconnected from my ears. I don't know what to do about the stomach part, but I relaxed. And that's what you have to do. In this weightlifting of myeloma, you have to spend and use all of your support team to help you. Hey, I got a big shout out there to Warwick, Rhode Island. Got a big support group watching us today. Thank you guys out there. I look forward to hearing about what you think. Now let's go on to the rest of the program, the meat and potatoes. We got relapse therapy and clinical trials coming up with a dear friend, Dr. David Vesole. And then life is a canvas. You are the artist from Kimberly Noonan. She's a good friend too. So sharpen your pencils and get your pens out, whatever you do to write. But now's the time. David, take it away.
Great. Thanks, Kelly. It's truly a pleasure to be here. But Dr. Cole following him is tough. let me tell you, I'm going like, whoa, I'm impressed. But that's really great. I will tell you that a lot of the drugs, side effects, so forth, the combinations he talked about are going to be repeated because that's what we do. What we use for patients with relapse disease almost always gets ultimately used in earlier courses of the disease, so earlier stages of the disease, if you will. So what he tells you about, he talked to you about the Griffin trial. Griffin trial was the 4-drug regimen. Well, most of the trials started with 4-drug regimens in patients who had relapsed or refractory disease, found out it worked, got moved earlier in the disease course. RVD initially was approved for patients with relapse disease, ultimately ended up in frontline treatment. So a lot of the stuff you're going to hear is repetitious, but that's okay. The more you hear it, the better it should sink in, I hope. So we're going to go over a lot of material. I'm not going to apologize. A lot of material that he covered because some of the same drugs that he talked about for frontline therapy and other therapies and other mechanisms are the ones that we use in relapse and refractory disease. So it's really a pleasure to speak with you all. I've done a number of the regional community workshops with Kelly. He's a fantastic moderator, friend, host, whatever you may say. And it's always a pleasure. I go after him because I like to do this. As you get older, as Dr. Cole referred to it, I call it mature, especially as I reach a very significant milestone coming this Saturday. As we mature over time, we don't want to call them old or geriatric. They're just mature adults. So without further ado, we're going to start talking about relapse refractory disease. And myeloma, even though I'm actually a runner, I should say a plotter, I don't think I can call it running anymore. I kind of put one foot in front of the other one 6 days a week, but I am slow as can be, like a snail, but I am determined to try to stay in shape and to get my exercise in. Exercise is good for you. So myeloma is a marathon. It's a long, steady course. It's not a sprint. Give me what you got right away, done. It's something that you have to deal with for a long period of time. Dr. Cole mentioned to you, it's sort of like having high blood pressure or having diabetes. It doesn't go away, but that doesn't mean we can't control it. Unfortunately, even though he showed you some fantastic data about the number of people, about 140,000 people in the US alive with myeloma, unfortunately, we still lose some of our patients to the disease. We run out of options, and the disease takes over. And this particular slide is kind of a timeline. So it starts off with either smoldering myeloma or MGUS, which is monoclonal gammopathy of undetermined significance. It's a benign condition where your immune system is just out of sync, out of whack. A small percentage of those, though, do evolve into smoldering myeloma, and smoldering myeloma can evolve into active myeloma requiring treatment. So bottom line is there's a precursor period of time that we don't usually pick up. The vast majority of patients with myeloma, we pick them up when they have symptoms. But there is biologically, we know this from some very elegant studies done at the Mayo Clinic and through the VA system, that essentially everybody who has active myeloma actually had pre-myeloma, if you will, earlier in their disease, earlier in their history. First-line therapy, Dr. Cole went over in detail about these fantastic responses of 95 to 100%. The first therapies used to say that was the first was the best. After that, it was a downhill course. That's not always the case, as I show you some data later on. In patients with very, very heavily treated myeloma, still can have response rates of over 95%. We didn't see this when I've been doing myeloma for 30 years. We didn't see this 10 years ago, 15 years ago, 20 years ago, wasn't even a thought. But now we have certain therapies, even in patients with very heavy treatments, can still have responses. But this is the general course. You get a good response with your initial therapy, you stay in remission, disease comes back. Usually subsequent therapies don't work as well and they don't work as long. And ultimately, some of the patients do expire, unfortunately, from this dreaded disease. So why, one of the questions is, why don't we cure the disease? So these balls that are kind of small are one of the examples. This is from one of the scientific publications. I'm actually going to give you a more down-to-earth explanation. But on these balls, if you just think of the reddish zone, I'm not sure if you can see my pointer. The reddish zone here is the main clone of myeloma. You get treated, that number of cells goes down, number of cells goes down, and the number of cells keeps going down. But what happens is some of the other cells that have myeloma start growing. So bottom line is, it's sort of like an 8-lane highway. 8-lane highway. In one lane is a Cadillac Seville, the second lane is a Lexus, in the third lane is a Toyota RAV, in the fourth lane you've got a Tesla, the fifth lane, whatever it is you want to call it. There's over 8 lanes of myeloma in any individual patient. There are over 8 different, some people think there's up to 12 different lanes of myeloma in any individual. So what happens? The Tesla takes off. That's the one that seems to be the most active. The Tesla takes off and starts going down the highway. And you come along and you give them, as Dr. Cole mentioned to you, you give them Dara-VRD. Dara-VRD stems on the brake, damages the motor, and the car stalls. That's a good thing. The car stalls. But what happens over time is the Lexus decides it wants to take off. So Lexus goes down the highway and you give them a different drug combination, the car stalls. After a little period of time, the Cadillac decides to go. You give it a different combination, the car stalls. But what happens? The Tesla, the first one, gets repaired. The cancer cells get repaired and it takes off again. So you're chasing after all these different clones of myeloma cells, and you never can eradicate all of them because they keep evolving and they can change over time. One of the questions in the chat was, does myeloma change over time? The answer is yes. Some of the genetics of patients with myeloma gets worse over time. You may have started off without some of those high-risk features that Dr. Cole mentioned, the 17p, some of the other ones, but later on in the disease course, it may start showing up because the cancer changes. It does whatever it wants. Why don't we cure it? Because there's too many lanes in the highway and the different cars are going at different speeds, and some of them are getting repaired, some of them are not getting repaired. So here's definitions. So I'm supposed to be talking about relapse refractory disease. I'm also going to talk about clinical trials. Relapse means the disease came back. So it can come back either as the bad protein in the blood. It can come back as the bad protein in your urine. It can come back that you have a tumor mass that we call plasmacytoma. It can come back as a new bone lesion. It can come back that because of the proteins that are being produced, It may cause problems with your calcium, may cause problems with your kidneys. It can come back, however, at once. Those are all the different things we monitor. So patients who are in remission, in general, particularly after transplant, we monitor every 3 months forever. It's not like some people, can we come at 4 months, 6 months? We do this to monitor for those particular parameters so that we can jump on it if we need to. So relapse means disease comes back. Refractory means you're on a treatment and it doesn't work anymore. You're getting worse even though you're being treated. So if you got the DARA VRD to start with, you had a transplant, you're on Revlimid maintenance, and all of a sudden the numbers get worse, you're refractory. First of all, you relapsed, but you're refractory to Revlimid. Progression just means that protein level, whether it's the blood, the urine, or the light chains, are going up. A line of therapy in myeloma is very confusing. This is very important. I want to explain this to you because when we talk about CAR T cells, because there's a question about CAR T cells, and there's going to be questions about the new bispecific antibody, it all depends on the line of therapy. So myeloma doctors can't count very well. That's one of the reasons there's only 3 stages in myeloma, whereas almost every other cancer in the world has 4 stages. Well, myeloma doctors also can't count lines of therapy very well. So if you get VRD, a transplant, and Revlimid maintenance, most of you will say, well, that's 3 therapies. Yep, no. In myeloma, that's considered 1 line of therapy because it was all planned sequentially. So VRD or DARA VRD, transplant, Revlimid maintenance is 1 line of therapy. To get some of the currently approved regimens, you have to have 4 lines of therapy. You have to have another 3 alphabet soups before you're considered to have 4 lines of therapy. Most of the clinical trials, which we're going to talk about later, start off with people that have had 4 or more lines of therapy. They test it in people who have relapsed or relapse refractory disease because that's the population they want to test new treatments on first. So someone's numbers start to climb. So, Janie Noonan, whatever, sorry about that, don't mean to use anyone's name, but Janie's M protein is 0. She's in a biochemical remission. She gets followed every 3 months. And then after 2.5 years of remission, that 0 comes a 0.4. Not very high, but her disease has definitely come back. It was 0 is 0.4. As Dr. Cole mentioned to you about responses, I need to explain to you about relapses. So we consider an increase of 0.5 to be a evidence of progression. But sometimes you can have, that could be 0.5, but it's not causing any problems. It's just there. So some of the patients that have a slight increase in that protein, whatever it may have been, so it went from 0.2 to 0.4, it looks like it's getting worse, but you don't have to do anything about it. It's not hurting them. It all depends on a lot of other clinical features we're going to talk about in the next slides. So there's a biochemical remission or progression where the numbers have gone up, but it's not causing any issue. And then there's a clinical relapse. So it went from 0.2 to 0.5, not very important, but all of a sudden their calcium's elevated because the disease is activated. That's a clinical relapse. Those patients absolutely have to be treated. It went from, they free lights, went their hemoglobin, they became more anemic. That's a clinical relapse. So we keep using that CRAB symptoms for clinical relapse, problems with calcium, problems with kidneys, problems with anemia, problems with your bones. So those patients require treatment. Some of the biochemical relapses, depending on a number of factors, can just be watched. So the question is, when do you need to treat a relapse patient? Do you do it right when the protein starts going up, whether it's the blood, urine, or free light chains? Do you do it if it's just up a little bit? Do you do it if it's up a lot? And as we already mentioned, at clinical relapse, the CRAB criteria, you have to treat. If you develop a new tumor mass, you have to treat. If you break a bone that we think is new to do bone disease, you have to treat. So those patients, not an issue. The biochemical relapses is much more, or I should say, much less straightforward. So before I go on to that, so part of the reason of how you decide if you want to treat depends on the disease biology. Patients who have high risk disease, Dr. Cole talked to you about the genetic abnormalities, the LDH that puts you in a stage. If you have high risk disease, even if you have a biochemical relapse, that predicts for a more aggressive disease. If you relapse, if you had a transplant and you go on maintenance therapy, the average time to stay in remission, some people stay in remission for 10, 15, 20 years. The average is about 5 years. But let's say you had a transplant, because one of the patients that sent in a question said they relapsed by 2 years. That means that even if they didn't have the genetic abnormalities, their disease biologically is aggressive, even though they didn't have the genetic features. You don't want to sit on those patients. Some of the patients can't tolerate the idea that they've got disease and no one's doing anything about it. They get anxious. Well, you have to do something, doctor. Well, the answer is that we don't really have to do something, because if you treat early versus treating later, if you have any symptoms or any abnormalities that require it, doesn't make you live longer. But some patients just can't live like that. And they go like, you've got to give me something. And it's not contraindicated. It doesn't make them live longer because we treated them earlier. But if it makes them feel better, and quality of life is the key for a disease we don't cure. Again, quality of life is the key. Dr. Cole talked about that. We want patients to have good health. We want them to have good quality of life, and we want them to have a long period of life. So when you figure about what should you choose when someone has their first relapse, depends if they had a transplant, didn't have a transplant, what their therapy was, did they tolerate it, did it work? Do they have other comorbidities? Do they have kidney problems? Do they have heart problems? How aggressive we talked about. There are psychosocial issues. Some of the patients just can't come in. Some of the treatments are given very frequently, and they just can't, they don't have caretakers or the wherewithal to come in. And unfortunately, in remote areas, you don't always have the same access. Insurance, I'm not going to deny insurance, but insurance approves almost all approved therapies. However, that doesn't mean there's not copay. So there may be a financial consideration to what we use as well. So this is some of the list of different categories of drugs. We're going to talk about these more. IMiDs, again, Dr. Cole talked about thalidomide, Revlimid, Pomalyst, proteasome inhibitors, Velcade, Kyprolis, Dinlaros, the oral one. We don't really give a whole lot of chemotherapy anthracyclines anymore. It's kind of, in Europe they do, in the US they don't. There are some other chemotherapy drugs. Melphalan's the drug we use for transplant. Bendamustine is kind of a cousin of it. And Cytoxan, these are drugs that affect the DNA directly. Steroids, those dreaded steroids, almost everyone gets dexamethasone. There's myeloma. There's a few clinicians who prefer prednisone. And there's novel drugs, which we're going to talk about some of these later. Two of them, I should tell you, were approved by the FDA, one called Faradex or panobinostat, and more recently, melflufen. They found out that they were approved on accelerated approval, meaning on phase 2 trials, which we're going to talk about later, about phase 1, 2, and 3 trials. They were approved on early trials. When they did more trials with more patients, they found out that they really didn't do so well, and either the FDA or the companies withdrew those drugs from the market. We are going to talk about Expovio. Venetoclax is not approved for myeloma, but absolutely has activity and does work. And Dr. Cole talked about a number of monoclonal antibodies. Tecvayli is not a monoclonal, it's a bispecific antibody. And then we're going to talk about CAR T cells. So we're going to forget the cellular therapies right now. I am going to talk about that later. In general, you pick like one from each category. Let's say you want 3 drugs. So you go, okay, I'm going to pick Pomalyst, Cytoxan, dexamethasone. And we found that, as Dr. Cole talked about, I'm going to show you an example in a second, 3 drugs almost always beats 2. 4 drugs often beats 3, but not always. So we usually use cocktails of 3 drugs. So the most common drug for first relapse is actually daratumumab, Revlimid or Pomalyst, and dexamethasone. We'll get into that in a second. So the problem is when you have all those drug classes and you have all those combinations, and I doubt that you can actually see this slide, but there's got to be over 25 different combinations that are in the guidelines of how to treat patients. So it's not unusual, not only for private oncologists out in the community, but even academic oncologists are going like scratching their heads, going like, "Oh my God, I've got all these choices. Which one do I pick first? Which one do I pick second?" And it is so confusing because there's, fortunately for the patients, there's so many different options available to you, and you've got to decide based on a variety of features which combination of drugs you want to use in which sequence. It's not easy because there's too many. So when I give talks to the private community, they always go like, "So which one do I use first? Which one do I use second?" So forth. I have my own opinion. Dr. Cole may not have the same opinion as I do. So this is a graph chart, if you will, from the Mayo Clinic. The Mayo Clinic, there's 3 Mayo Clinics in the country, one in Rochester, Minnesota, one in Scottsdale, Arizona, and one in Jacksonville, Florida. And there's about 25 myeloma doctors in those 3 facilities. They get together and they come up with guidelines that they recommend for their patients. That does not mean that anyone else has to follow, but they're guidelines. So for patients in first relapse, if they were not refractory to lenalidomide, if they weren't on Revlimid, then there's a variety of things to do. If they're not refractory, you could go down this route. You could give them Dara-Rev-Dex. If they were not refractory and they relapsed while they were on an antibody, on daratumumab, Darzalex, or Sarclisa, then they recommend a different cocktail. If they're refractory to Revlimid, lenalidomide, they recommend this route, either DKD or DPD. If they were refractory to a monoclonal antibody and Revlimid, then they recommend KCP or KPD. But there's still alternatives. So there's still, even their guidelines give you a number of different options available to them. So I just want to prove 3 is better than 2. Dr. Cole showed you data on this. He actually showed you Dara-VRD versus VRD. This was a trial done for patients whose disease came back, that they had 1 to 3 lines of prior therapy. They got DRD, Darzalex, Revlimid, Dex in one group, Revlimid, Dex in the other. So it's 3 drugs versus 2 drugs. So when you look at these curves, and Dr. Cole showed you those, the curve on the top wins the race. So at 30 months follow-up, look at the 3 drugs, 58% of the patients were still in remission with 3 drugs versus only 35% of the patients with 2 drugs. 3 drugs beat 2 drugs, and that's almost always true. So in general, we give 3 drug cocktails as long as we can because 3 beats 2. The next ones are different regimens using, and he mentioned these are just to go in more detail over different drugs that are available for people who've had 1 to 3 lines of prior therapy. So you've got Dara-VRD, initial therapy, you got transplant, you went on Revlimid. Disease came back. How are we going to pick this? Well, in theory, Revlimid would be a good choice. You could give Velcade again because it worked and you're not relapsed to it. Velcade essentially only should be given as a subcutaneous injection. You could give a cousin of Revlimid called Kyprolis, which is an IV. It's given weekly, 3 out of 4 weeks. You could give an oral regimen, an oral drug in that class called Ninlaro. It's only given once a week. It works. It's a little less effective than the injection or the infusion. Revlimid and Pomalyst are once a day pill for 21 days of the month in general. And Expovio, which we're going to talk about later, is a new drug. It's approved for patients who've had 1 to 3 lines of therapy in combination with Velcade dexamethasone. It is a very unique mechanism. We're going to talk about that a little bit more later. But these are the different drugs. You could combine whichever ones you want, but you would pick one from the proteasomes, one from the imids, or you could pick one from Expovio, the selinexor. So this is just comparing. Again, we talked about 3 drugs versus 2. So this is 4 different trials. of some of the drugs we just mentioned. 3 drugs versus 2, Velcade, Pom, Dex versus Velcade. The triple drug was 11 months versus 7 months. So if the 3 drugs beat 2 drugs, this is Kyprolis Revdex versus Revdex. The triplet beat the other one by 9 months. This is Ninlaro Revdex, the oral pill that's a proteasome inhibitor with the immunomodulatory drug, 21 months versus 15 months. And then the Boston trial Expovio, Velcade Dex versus Velcade Dex, 14 months versus 9 months. So these are all different drug combinations you can give. Some of them look to be better than others. They don't have the same side effect profile. Doctors got to pick which one they feel comfortable with and which ones they know that they know how to modify when you have side effects to it. So how do we decide which proteasome inhibitor? Velcade causes peripheral neuropathy, numbness, tingling, burning, pain in up to 20-25%, only a few percent with severe, but 20 to 25% with some neuropathy, of which most of those will get better, but some don't. Kyprolis, less neuropathy, can cause cardiac problems. 5 to 8% of the patients on it for a period of time can have cardiac problems, can cause high blood pressure. None of these drugs need to be adjusted for people with kidney problems, even if they're on dialysis. Ninlaro causes almost no peripheral neuropathy, but does cause some mild GI toxicities, nausea, and diarrhea. When you look at immunomodulatory drugs, didn't include thalidomide on here, both of them could cause rash. They can cause GI problems. Revlimid is more likely to cause diarrhea. Pomalyst is more likely to cause constipation, but it can vary. They both increase the risk of blood clots. You have to be on a blood thinner if you're on these drugs in combination with steroids. There is a slight risk of second malignancies. It's all related to some of the other therapies, but there's a small risk of getting a second cancer if you go on this class of drugs. And I should tell you that there are 2 new drugs, neither one approved yet, and I don't think I have it in my slide deck, that are, one of them probably about maybe a year from now, is the same immunomodulatory drugs. It's called a CellMod, but it's a cousin of it's a cousin of these drugs and how they work in the cells that causes even less side effects than these 2. It's called right now, the generic name is iberdomide. I can't tell you if it's got a trade name yet. And there's another one that's also mexilamide. Expovio. So Expovio is approved for 1 to 3 lines of prior therapy. Expovio is very unique. So think of, most of you can remember from your biology, I don't have a picture of a myeloma cell here right now. Myeloma cells have a nucleus, kind of the dark part in the cell, and then there's the bigger, so it's a small balloon and a big balloon. Let's just use that as a thing. Well, in the small balloon, which is a nucleus, that's where all the DNA is. That's where the manufacturing of the cell goes on. So the DNA manufactures everything. One of the things that the DNA manufactures is a protein called tumor suppressor genes. Tumor suppressor genes do exactly what it says. It suppresses cancer cells. So the DNA makes something to suppress the likelihood of suppress the likelihood of a cell becoming malignant. What happens in cancer cells is there's a revolving door on the outside of that balloon where the DNA is, and the revolving door is spinning, and when it spins in a cancer cell, it spins the tumor suppressor gene and kicks it out of the nucleus. So it stops the tumor suppression because it gets kicked out through the revolving door. Expovio puts a door stop in the revolving door. So if the if the door's not revolving, those tumor suppressor genes stay in the nucleus, and the cells can die from the chemotherapy affecting those cells. So this drug is called a nuclear transport inhibitor, but essentially puts a doorstop into the nucleus. So the bad things that you want, the proteins you want, so the cell will die, don't get kicked out. This drug can cause a lot of GI problems, and it's got to be very aggressively dose adjusted for people who can't tolerate it. You need to be on long-term medications to control the nausea. It also decreases appetite. Even if you're not nauseous, just makes people not want to eat. So there's a number of other things it can do here. It can cause low blood counts. Everything we do can cause some fatigue. It can also cause some electrolyte abnormalities. So this is an approved drug, not an easy drug to use, but is effective either by itself or in combinations. Monoclonal antibodies. So Dr. Cole talked about some of the monoclonal antibodies. I use a little bit different analogy for monoclonal antibodies. I think of the myeloma cell as having different colored houses on the surface. So there's a house, a red house, and the Darzalex and the Sarclisa attack red houses. Okay? There's a blue house. Implicity attacks a blue house. The drug that we're going to talk about in a little bit, the new bispecific teclistamab or Tecvayli, attacks a greenhouse. So these antibodies are made against the blue house. There's an antibody made against the greenhouse. There's an antibody made against the red house. And that's the way they work. So the different antibodies, they're all approved. They're all approved for patients that have recurrent relapse disease. Even though he talked to you about the 4-drug regimen of DARA, VRD, that cocktail is not yet approved in the US. It will be probably very soon, but they are approved in the relapse setting. Darzalex is either subcutaneous injection under the skin or it comes IV. Implicity is a different target. It's given IV, and Sarclisa, which is a first cousin of Darzalex, is not yet subcutaneous, but it's given IV, and they're not given exactly on the same schedule as far as how often they're administered. But these are the current FDA-approved antibodies. There was another antibody. I showed you before in one of the charts that 2 of the drugs got pulled from the market. There was another antibody that actually was a very unique concept. It was an antibody that had a drug attached to it. So it's like an antibody that attacked a yellow house, but it had a nuclear bomb attached to it. So the antibody would attach to the yellow house and then set the nuclear bomb off in the house. It would blow up the myeloma cell. That recently, just a couple months ago, got pulled from the market because when they did the follow-up studies, it didn't show enough activity. So that drug, which is called Blenrep, is no longer available, but there was another antibody. So this is, again, 3 drugs versus 2. Darzalex Revdex versus Revdex, 45 months versus 18. Darzalex Velcade Dex, and some of these numbers, they're not always exactly the same population, so don't take it that way. Darzalex Velcade Dex, 17 versus 7. So 3 drugs continue to beat 2. I should tell you that Sarclisa, Kyprolis Dex, again, Sarclisa is the first cousin or almost a twin of Darzalex. It was 41 months versus 15 months. But again, the trials weren't done exactly the same. So I don't want you to focus so much on this one seems to be better than that one. You really have to compare apples to apples. And not only apples to apples, you have to compare, Granny Smith apples with Granny Smith apples. You can't do Granny Smith apples compared to Honeycrisp, even though they're all apples. So some of these trials are not done in the same populations. The point here is that 3 beats 2. These antibodies are very effective. So this is more antibodies, 3 versus 2, with Implicity, which attacked, I can't remember if it was the blue house or red house, whichever house it was, not important. 3 drugs versus 2, 19 versus 15 wasn't very impressive, but did get approved based on that. Here is Implicity Pomdex, 10 versus 5. Sarclisa, which is the one that's very similar to Darzalex, 3 drugs versus 2, 12 versus 7. And this is the one I just told you, 3 drugs, 41 versus 19. So again, this is that Mayo Clinic flow chart. What do you do with people? The one I showed you before was first relapse. This is second or more relapses. Refractory to IMiDs. IMiDs, again, are Revlimid, Pomalyst. PIs, Kyprolis, Velcade, Nimlaro, anti-CD38 is the Sarclisa or daratumumab. You could give a combination with cyclophosphamide. You could go on a clinical trial, which we're going to talk about. You can give anti-BCMA strategy. One of them, again, this was a different colored house. One of the drugs that got pulled was the one that was attached to the nuclear bomb. But we actually have 3 different BCMA targeted therapies. BCMA stands for B-cell maturation antigens, a different colored house on the surface of the myeloma cell. And we have 2 CAR T cells that attack that, and we have 1 approved bispecific that attacks that. If you're refractory even to a BCMA, then it really gets tough. You can go on selinexor, venetoclax, which is not approved, but we can get for our myeloma patients. Bendamustine, also not approved for myeloma, but we can get this readily for patients, or go on one of the clinical trials. So we already talked about this. The selinexor, it was, I don't know why the slide's messed up. Let's just skip this slide. So this is the selinexor. This is one that puts the block in the revolving door in the small balloon inside the big balloon, if you will, the nucleus of the cells. When you look at it in a group, when it's combined with dexamethasone by itself, it's got about a 25% response rate. If you're not refractory to all these drugs, it's got a much higher response rate when you combine it with either Darzalex, Pomalyst, or Velcade. But again, this drug is one that has to be very closely monitored for GI toxicities. Emerging therapy, bispecific antibodies. So let me just give you my interpretation of what a bispecific antibody. Think of a fork that has tines or prongs on both ends. I'm going to show you a picture of this in a second. So you've got a fork that's got prongs on both ends. One prong, one end of the fork gets stuck in the myeloma cell. The whatever color house I made it, yellow, green, I think it was green. So one of the forks gets stuck in the greenhouse. The other prong gets stuck in one of your immune cells, and they're very closely proximitated to each other. So you've got the immune cell right next to the myeloma cell because the fork's sticking into it. So the fork is doing its damage on the myeloma cell by itself. And then on top of that, you pulled in the immune cells to let them do the dirty work. So there are a number of bispecific antibodies. There's only one approved. I'm going to show you some data on the others. The one that's approved is against this target, the house, the greenhouse, whatever color house it was, is BCMA. But there's other houses. There's a white house. There's a lavender house. There are other types of houses that we have bispecific antibodies directed to. Again, one of the prongs is going to stick into the house. The other prong is going to stick into the immune cells. That's one class of drugs. Another class of drugs is the drugs that are very similar to the thalidomide, Revlimid, Pomalyst. They all work on the same mechanisms called the cereblon E3 ligase modulators. Iberdomide is the one that's probably, I think, is going to get approved sometime in the next year and a half. But there's another one called mexilomide, I think is how you pronounce it, that also works that way. These drugs, even if you're refractory, you don't respond to Revlimid, you don't respond to Pomalyst. If you give iberdomide, 25% of the patients will respond to that drug, even though it's a first cousin of Pomalyst and Revlimid. So this means you could go from one drug in that class to another and still get activity. Again, it's a capsule. It's going to be given 21 days a month, just like Pomalyst and Revlimid. And then there's another one, mexilomide or CC480, also seems to have very good activity, 25-30%, even if you failed the other drugs in the same class or essentially the same class. And both the iberdomide and mexilomide have less side effects than the Revlimid and the Pomalyst. Then there's some small molecule inhibitors. The venetoclax, which attacks a specific gene pathway called BCL2, is not yet approved. It's been, again, they did a trial, 3 drugs versus 2. The 3 drugs won. But what happened was that in the patients who had venetoclax, the venetoclax arm had a lot of infections, so the FDA didn't approve the drug yet. It's going to get approved for myeloma. And we've been able, through compassionate programs, to get venetoclax for a lot of our patients. About 15% of the patients have this BCL2 in their myeloma cells, And that group, particularly if you give venetoclax, does very well with that drug. CAR T cells. So CAR T cells are taking your own cells, not the same as collecting your stem cells. With stem cells, they have to give you either chemotherapy or medications that stimulate your white cells to go up, and then you collect them out of the bloodstream. With CAR T cells, they just hook you up, do not have to give you anything beforehand. They collect one of your white blood cells. They genetically engineer them by programming them with a program that does two things. One, it programs you to attack the myeloma cells. So it attaches to the myeloma cell. And the second thing it does is it arms them with missiles. So you have genetically engineered the cells to attack a certain colored house, and you've given the cell missiles to shoot at the damn house. So those are what CAR T cells do. They grow them, they genetically engineer them, they grow them and expand them in the laboratory, and they give them back to you. There are two different companies that have approved CAR T cells. One's called Abecma, the other one's called Carvykti. I'm going to show you some brief data on that. One of them takes about a month to be manufactured. The other one takes about 50 days to be manufactured. So that's what's shown here. You get your cells collected, called lymphopoiesis. Takes 4 to 8 weeks to generate the cells. You do receive therapy to suppress your immune system, because even though we're giving you back your own cells, they're modified. We don't want your body to reject them. So we give you medicine so you don't reject the CAR T cells. And it's usually given over 2 or 3 days, depends which cocktail you get. You get the cells. You have to be in the hospital for, depending on the institution, 10 to 14 days, and then you get followed up. You're done after that. The infusion takes minutes. So these are basically, and again, they're not dealing with the same apples, if you will. Again, it's not both Granny Smith. One's Granny Smith, one's Honeycrisp. But when you look at Abecma, the response rate was 73%. The patients that got this, the average number of prior lines of therapy was six different cocktails of drugs. 73% of the patients still responded, and about 25% went in complete remission. With Carvykti, the response rate was 98%, and the likelihood of getting remission was, I should say complete remission, was about 80%. Again, don't get confused. It's not the same apple. Average time that patients stayed in remission was about 9 months with the Abecma, and it's actually hasn't been reached. The projection is about 2.5 years with Carvykti. No free lunches, guys. No free lunches. Main side effects, you have to be in the hospital because you can get a cytokine release syndrome. Cytokine release syndrome, in the plainest language, is sort of like makes you feel like you have the flu for a couple days. But with fever, it can make you short of breath, can give you headaches, it can give you nausea, give you low blood pressure, same things that you can get. Essentially with the flu, we do have an antidote that we can give to fix this, called tocilizumab or steroids. It can also cause neurologic side effects. The most common thing is headache. But some people have a little confusion. Some people have some motor disturbances. I personally have been treating patients with CAR T cells for myeloma. I've never seen seizures. I've never seen delirium, but there are cases of that. And with the Carvykti, there's some very late cases of neurologic toxicity. Most of these toxicities, depends which product you get, happen within the first week of receiving the CAR T cells. We don't really understand exactly why this happens, and it can last for, it says here, duration 5 to 11 days, 3 to 17 days. Most of these things are come and gone by 2 to 4 days. So most patients could be out of the hospital. At least our institution, we discharge them at about 10 days after. All the clinical trials require 2 weeks. The problem with CAR T cells, it's a one and done thing, is that sort of like the automobile cars, a year ago, you couldn't get a new car because they didn't have enough computer chips. Well, the way they genetically engineer the immune cells that we've collected from you, they don't have enough of the computer chips, if you will. So there's not enough product that can be made. So these red stars are the sites in the country where you can get it. I work in 2 hospitals, one in New Jersey, one in Washington, D.C. We don't have it in Washington, D.C. They haven't opened up any new sites for over 2 years because they can't make enough cells. They don't have the manufacturing capability. That's what's shown here. A lot of the patients who meet the criteria, 4 or more lines of therapy, are good candidates for CAR T cells, but they can't get a slot. We have a waiting list of over 20 patients. And we are now getting 2 patients a month on one product, and I think they just increased it to 3 patients a month on the other. We have a very, very active myeloma program. What's the difference between the two? Well, CAR T cell therapy, we do collector cells, we do for stem cell transplant. The cells that we genetically engineer are called T cells versus stem cells for transplant. There is genetic engineering for the CAR T cell, not for transplant. You do receive chemotherapy before transplant. That's what fixes the patients. In CAR T cells, we give therapy to suppress your immune system so you don't reject the cells. That immune therapy does not do anything for the myeloma. And the course after that is we don't give CAR T cells currently, only approved for 4 more lines of therapy. CAR T cells usually given for frontline therapy. And I'm not going to go over the side effects of transplant, Dr. Cole did. And we talked about cytokine release syndrome and neurologic toxicities. We talked about bispecifics. This is actually a trispecific. So here's one fork being stuck into the immune cell called the T cell. The other fork is stuck into, this is a trispecific, an accessory cell, but here's the other fork in the tumor cell. So just think of these two, of how that's working. And that's what's shown on here. I'm going over time, so I'm going to speed up. This is the only ones approved currently, called teclistamab or Tecvali. Patients had to have 4 or more lines of prior therapy. It's a subcutaneous injection. You have to be in the hospital for the first 3 injections. Currently, it's approved for days 1, 4, and 7, because this same bispecific can cause that same CRS, that flu-like syndrome, or the neurologic toxicities. So you have to be in the hospital for the first 3 doses. You start with a little dose the first day, you get a little bit more dose the second injection, and the 3rd dose is the full dose. Response rate in this group of patients, 63%. Median duration of response predicted to be 18%. And a third of these patients with very heavily treated myeloma are still responding to the bispecific antibody. Let's not do that. CRS, common, this flu-like syndrome, 72%. If I showed you the neurotoxicity, which may be the next slide, is 57%. I'll have something. Again, most common CRS is just fever, generally low grade. Most common neurotoxicity is headache. So these are a variety of bispecifics. All this group up here are responding to BCMA. There was, I think it was the green house, but here's the GPRC5D attacks the pink house, the FCRH5 attacks the white house. You could actually get one and then the other. The only one that's approved right now is teclistamab. Elranimab's probably getting approved sometime in the next year. The other ones are a little bit farther. Talquetamab is actually probably 2 years away from being approved. So we should have another BCMA-targeted bispecific soon, and probably in the next 2 years, we're going to have a different target. So you can go from one to the other. Side effect profile is about the same. This is just a generic listing of a variety of trials of these bispecific antibodies. So we talked about this cytokine release syndrome. All of them are 60 to 75% neurotoxicity. One of them was a little bit lower, 40 to 55%. It can cause low blood counts. One thing that does happen is it screws up your immune system for a very long time. You get these drugs continuously till they don't work. Teclistamab's every week injection. The other one I mentioned that should be approved in the next year, elranimab's every 2 weeks. So you keep getting exposed to drugs that suppress your immune system. You're highly susceptible for getting infections. So CAR T cells versus bispecifics. I'm not going to go over this because I'm way over time. I always like CAR T cells because it's one and done, unlike the bispecifics, which is either once every week or every 2 weeks. There are new programs to make them less frequent, but right now, the one that's approved is every week. CRS and neurotoxicity more likely with CAR T cells than bispecifics. The bispecific advantage is you just walk in the doctor's office, they order the drug, you get it. Doesn't take a month to 2 months to manufacture it. Key points: CAR T cells, bispecifics, very active, even in patients who've had heavy treatment. Some of the CAR T cells average was 6 lines of prior therapy. The bispecifics, I think, was 5. Side effects are manageable. It's much easier, even though you may be scared. Going through a bispecifics and CAR T cells far, far easier than a transplant. You don't lose your hair, you don't have nausea and vomiting, you don't get rashes. And the side effects are very limited. And the recovery, once you get over that short period of side effects, it's not like you still don't have normal bowels for weeks after or months after you've had a transplant. These Abecma and Carvykti, the first generation, there's certainly more coming along. There's different targets. Those are both BCMA targets. Bispecifics, you can just order it and get it the next day. You don't have to wait to have it manufactured. Clinical trials. There's only about 3% of patients with cancer that actually go on clinical trials. I'm going to zip through this because you guys can get copies of my talks. There are 3 phases. Only 3% get this. There's 3 different phases of clinical trials. I just want to go over that so you understand that. Clinical trials, if we didn't have clinical trials, you wouldn't have any of these drugs I'm talking to you about. Someone's got to be treated with clinical trials. You get monitored much more closely. You get catered to when you're in a clinical trial, and this is what leads to new drugs being developed. So what happens with a clinical trial is somebody comes up with an idea, they test it in the lab, they test it in animals, and then they decide that if it worked in the animals, it's time to test it in people. So there are 3 phases of clinical trials. Forget the 4th phase. First phase is just to see what's the right dose. So think of it as you've got a headache, and you want to know how many aspirin it takes to fix a headache, right? You want a new aspirin. So the phase 1 is to take 1 aspirin for 3 people, see if they tolerate it, not if it works, see if they tolerate it. Take 3 more people, give them 2 aspirin, take 3 more people, give them 3 aspirin, take 3 more people, give them 4 aspirin. Eventually you're going to have some side effect from 4 aspirins. Let's say you had GI bleeding, and they're going to say, well, 4 aspirins is too much. We're going to use 3 aspirins. So in phase 1, we just decide how much drug can be safely administered. Phase 2 decides if that new drug works. And in general, this can be anywhere between 60, in myeloma, it's never 300, 60 to 100 patients that you give them 3 aspirins, because 4 was too toxic. Or aspirin equivalents, we gave 60 people 3 aspirins. We want to find out how effective it is. We find out 25% of the patients responded to 3 aspirins and their headaches got better. Phase 3 is we take the new drug and we compare it to an old drug. So let's say we had a new aspirin and we're going to compare the new aspirin to Bayer aspirin. So we want to take up to usually hundreds of patients, 300 to 500, and in some diseases over thousands of patients. You take old drug versus new drug. No one's getting a placebo without getting an active drug. So one of the reasons people don't participate is they're afraid they're going to be given a placebo. You do not give cancer patients just a placebo. You have to give them active drugs, or it's not ethical. So you may get a active drug with a placebo or a new drug with a placebo, but you always get a drug that works when you do treatment with cancer patients. What are the benefits? You receive at least standard treatment. The new treatment may actually be better, and the new treatment may help improve your cancer care and that of others. So without further ado, I think I'm going to stop because I'm way over time. Sorry, folks.
That's okay, David. That was a lot of great information, though, and it's a tough topic to cover in 15 seconds. I got a couple questions for you. Once I was on a cocktail of drugs, but that failed. Can I sometime, if it's after a period of time, can I go back on the same cocktail of drugs?
So in general, if you were on a cocktail and it stopped and and the disease progressed, so you're on ABC, disease progressed, and then you got DEF and you got GHI. Can you go back to ABC? The answer is no. It doesn't really work.
Now, another person said, why aren't we just using a single drug? They used a brand name. I won't repeat that, but why aren't we doing that?
So between Dr. Cole and myself, I hoped we convinced you that 3 drugs beats 2. So you can't, logically, if 3 drugs beats 2, 2 is absolutely going to beat 1.
Sure.
So it really is not a consideration. We almost never, CAR T cells, you could say, is a single treatment, but although you get something beforehand, but no one uses a single drug. It's just not effective by itself.
Okay, let's move on to the next speaker, Kim. Thank you, David. I appreciate your time today and your evening since you're on the East Coast. Our next speaker is doing a brand new deck. It's called How to Manage Side Effects. That is what the deck is, but it has a new life as a canvas. You were the artist. Thank you, Kimberly. I totally got that messed up. Anyways, Kimberly has a lot of degrees, a lot of experience, and she works at Dana-Farber Cancer Institute in Boston, where I bet it's cold there today, is it?
It's cold there, and plus I have alphabet soup at the end of my name. I get that. So, boy, it really is an honor to be here tonight. And as the last speaker, it is just, these are tough acts to follow, right? 2 amazing speakers. I could not believe all the data that has been generated this evening. So your heads must be spinning, as Dr. Cole said. It is amazing that in 10 years, we have had 32 drugs that have been FDA approved. So that's why you're the artist, because we have so many options for you, right? So what I'm going to talk about, I came with my bright slides, but also that the future is bright. And when you stop and think about the fact that we're going to talk about how you're going to live your optimal life with myeloma, because you're going to live for a long time. So the objectives here, we're going to look at some treatment. We're also going to look at how we're going to manage these side effects and as well as infections. And then we're going to look at, who's your healthcare team and how you're going to navigate those visits. So what's good about me, I'm from Boston, I talk fast. So I will make up some time for everybody. So that's good. So here we have this color wheel of treatment. So there's lots of colors in people that have multiple myeloma. So, we have treatment, but we also have lots of ways to treat your symptoms, and we have lots of supportive care. So with that, what are the goals of your therapy? So the myeloma therapy, we know we want a durable disease control. We want a rapid and effective, time frame, but we want to minimize side effects. We want ultimately for you to have an optimal quality of life. So supportive therapies are on the other side. How are we going to manage your symptoms? How are we going to optimize your quality of life and optimize your symptoms? All right, so we'll take a step back, and when you look at how we treat people, so right from the beginning, we're looking, are you transplant eligible? Are you transplant ineligible? Usually sometimes age, sometimes sort of organ dysfunction will determine whether you are ineligible or eligible for transplant. But as you can see, a lot of it looks the same. There's consolidation, there's maintenance on both sides. There's supportive care throughout. So there's a lot of similarities no matter what we do. And so when you think about patient-reported symptoms, there's physical symptoms, psychological symptoms, and I'm really happy to see that there's financial issues too. I think that this is the first time I've seen this in any of our slides. So when we're looking at physical symptoms, it's that fatigue, it's GI symptoms, constipation or diarrhea, it's pain, neuropathy, and also it's, impaired physical function. We can't really help you unless you really talk about these things. So it's important to sort of keep a diary. I often say to patients, when do you get the pain? How does the pain occur? What helps your pain? What doesn't help your pain? keep a diary so you can report that back. But psychological symptoms, depression, anxiety, sleep disturbance from all of the therapy that we're giving you, the steroids, maybe decrease in your cognitive function, maybe your social roles too have decreased. But look at the financial burden. People often have to leave their jobs. They have to, really delay. Life is sort of on hold for a little while until you can get this under control. So with that, there really are a lot of things to manage that you should really manage with your healthcare team. And we're going to get into a lot of that. When you look at, as we heard Dr. Cole talk about auto transplant and when to do it, and we saw that New England Journal of Medicine article, and I just loved, I have to take 1 minute. That slide, Dr. Cole, on that New England Journal of Medicine was profound, where, we had happy faces on both sides and what should we do? There's no black and white answers to when to undergo a transplant. And, it's really about your commitment. It's your support system as well. And sort of understanding the process is also going to help. There's clinical experiences, data from the research, as we saw from the New England Journal of Medicine, but there's also your preference, and that really matters here. Okay. And so right here, we're just going to take a step back to talk about the bright and the dark side to steroids. I tell my patients all the time, steroids are the drugs you love to hate. We know that it potentiates our therapy. We know that we need them. They're synergistic. But look at this person on your right-hand side. There's mood swings. There's difficulty in sleeping. There's weight gain. There's, reflux from, hiccups. There's an increase in infection, muscle cramps. Diabetes can occur as a result, and edema or, water retention. So what can you do to sort of, navigate these symptoms? Well, try to take them steroids at the same time every day on a consistent schedule. Take it with food. But if that doesn't work, I have a lot of patients that wake up at 3 a.m., take their steroids, go back to sleep. By the next day, they feel like they might be back on track. So talk about that again with your healthcare providers, because we have a lot of tricks up our sleeves that we will use. So now we're going to look at how you're going to manage the symptoms. We're going to look at infection. And so we see that, there's infection, whether it's BCMA targeted, but there's just infections related to our therapy. There's infections related to having multiple myeloma and having an increased burden of disease. And so, looking at COVID and looking at myeloma, there's an increased risk factor of COVID complications. But we have so much better treatment on the market these days. We have Paxlovid, we have remdesivir these days is what we're using for our monoclonal therapy. Evusheld is something that we use, not to say we won't use it in the future, but we have a lot of ways to treat COVID. People that have myeloma certainly are at risk. They're at a 7 to 10-fold increased risk of bacterial and viral infections. And so there's certain preventative mechanisms that you can use, like good personal hygiene, but avoiding, crowd control, but, avoiding crowds in general. We have growth factors, but also being up to date on your immunizations is very important. COVID, Shingrix, for example, for shingles. Then the new pneumonia vaccine is very vital as well. So try to be up to date. The flu vaccine, without that goes without saying. And medications, antibacterial medications. If you do get sick, it's important to call your healthcare providers, let them know. And so when you're thinking about living, and what strategies are we going to use for prevention? And so here we have managing your stress. And so you're probably back there thinking, come on, is she crazy? I'm going to manage my stress while I'm at the hospital all the time. But I'm telling you, there really is a lot of ways to manage stress. Being socially engaged is important. Complementary therapies, as we saw, as we took that break, you almost had to wake me up at the end of all of that. It was fantastic. But maintaining a healthy weight, trying to walk, trying to exercise as much as you can. Prevent falls, stop smoking, alcohol intake, I think is very important to minimize that as much as you can. Dental care is important, certainly with our bone strengtheners. maintain your renal health by appropriate hydration and avoiding drugs that are toxic to your kidneys, diabetic management as well. Protect your bones with calcium and vitamin D, as well as weight-bearing activities and bone strengthening agents.
All
right, and so I think it's time to just really recognize our care partners that support us through our entire journey of multiple myeloma. And so, we need them certainly through transplant, we need them through CAR T, but we need them through every therapy that we receive for people that, for the patients that have myeloma. We need them for, obviously for sedative procedures that we're doing, like maybe a bone marrow, but we need them to take notes. We need them to show up at your next appointment, take notes, and be able to sort of talk about that after. All right, and so now we're going to get into the symptoms, and maybe there'll be more questions as we open it up at the end. But certainly we have diarrhea on one side, constipation on the other side, and we have lots of strategies to manage that. But diarrhea can be caused by laxative, obviously, but antibiotics, antidepressants. And so the way that we can really navigate those symptoms is avoid things like caffeinated drinks, and we could take Imodium, but cholesterol is something I think Dr. Cole talked about earlier. Lamotil is another agent we can use. We can use Metamucil, Citracel, Benefiber for both diarrhea as well as constipation. You see it on the other side as well. And so constipation, so the universal side effect for opiates or narcotics that we use to control pain is constipation. Antidepressants can cause constipation, but so can calcium and iron. And so pay attention. If you're feeling like you're constipated, a lot of our therapies are going to cause constipation and they're going to cause diarrhea. Kind of figure out what it was that did it and keep that journal that we were just talking about. But by increasing your fiber with fruits and vegetables and high fiber whole grains is one way to manage this. Fluids can help this, as well as an increase in mobility can help constipation as well. Okay, so pain prevention is the next symptom that we're going to talk about. So pain can obviously compromise your quality of life. And so some of the sources of pain is going to be bone disease, maybe neuropathy, maybe it's that medical procedure that we just did, the bone marrow or something. So we prevent fractures by giving bone strengtheners such as denosumab or zoledronic acid. Interventions depends upon where the pain is coming from, obviously. We want to look at your calcium levels, but we need to image. If you have pain, really, I think advocate for yourself, maybe your support systems, advocate for your loved ones, that this needs to be worked up. Pain we don't really like to see. We want to find out why you're having the pain. Complementary therapies can help pain, as well as, lots of medications that we use. Acupuncture, as well as yoga is certainly a way to manage your pain. Lots of ways to manage pain. You could be referred to the pain service, the pain clinic. There's so many interventions that I really hate to see that people are in pain when they have multiple myeloma. Peripheral neuropathy, I did see one of these questions in the chat. It's described as, I have numbing or I have tingling. There's a prickling sort of sensation. I can't even touch my arm because I have so much pain. And then muscle weakness. So, how are we going to manage this? Well, some of our drugs that we talked about, some of the proteasome inhibitors such as bortezomib or Velcade, ixazomib or Nimlaro, as well as carfilzomib or Kyprolis can cause, as well as even lenalidomide can cause some peripheral neuropathy. We can manage it by decreasing your medications, taking away medications. So talk about that again with your healthcare providers. We can extend or delay your therapy until symptoms are better. And so some of the way that we're going to manage this is with vitamin B complex medications, folic acid. We can also use drugs like duloxetine or Cymbalta, as well as Neurontin or gabapentin or Neurontin, or pregabalin is another way that we could treat it. But there's lots of ways to treat it. We can even I often send our patients to our neurology service if the peripheral neuropathy really doesn't seem to be improving despite some of our strategies to try to manage it. Topical ointments or topical creams can also be obtained through over-the-counter. So whatever works for you kind of works for you. And really just keep trying a lot of different agents, I think, to get at what's going to help these symptoms. So fatigue, anxiety, depression, I would say that, 100% of my patients that I see report fatigue when they're on therapy, but especially when their disease is not very well controlled. But other sources, anemia, pain is exhausting, right? If you are very fatigued, if you have insomnia, you might have an increase in fatigue as well. Anxiety is reported in greater than 35% of patients with myeloma, and depression about 25%. And so, talk to your team about these symptoms, and we really want to help. We can lower doses if we have to. We can give you a little bit of a break as well, but we really need to know about the symptoms. Financial burden, as I said before, I'm glad that this is part of it. What causes the financial burden? It's sort of our high premiums. It's our co-pay. Maybe it's the travel. Maybe it's just getting in and out of the garage every day that costs $40, right? It's kind of crazy. Medical supplies, prescription costs. We all know that the therapy that we give you for myeloma is not cheap. And so, loss of income. People have to take time off from work. Caregivers do as well. And, it's important to talk about these things. I know where I work, we have access management to help with that. Social services can help. As we can see, there's federal programs, there's pharmaceutical supports, there's nonprofit organizations, and here are some websites as well. So lastly, I'm going to talk about framing your care. Know who's your healthcare team and how are you going to prepare for your next visit, and what is shared decision making. And so look at that team of people. I mean, that is a busy slide, right? And so we see that we have a general oncologist that maybe you see locally, but then we have, Dr. Theurer here as our myeloma specialist. There's a support network that you're going to be working with, your caregiver, as well as the allied health staff. So nurse practitioners, physician's assistants, your research nurse, your oncology nurse navigator. Who are the subspecialists that you're working with? Is it a cardiologist? Are you seeing an orthopedic surgeon? What about the role of your primary care in all of this? And so I think it's important to understand, I'm here for, a primary care visit. Are you going to take care of my blood pressure? I'm here for today, Dr. Theurer, to see you for my myeloma. What are we going to do the next time my M protein is elevated? What are we going to do about that? And then you're really sort of communicating that. And I think now with our EHRs, we do such a great job of communicating between the teams of people. What is the nurse practitioner going to do for you, versus the research nurse? I think it's confusing, but it's also very important to understand what everybody's role is and communicate to your team. Really, that's all right. I'm going to be able to use the research nurse for this, but what's the role of the ONN? All right, so prepare for your visit. I love this because bring the list of your medications. If you have a previous list of medications from your last visit, bring that with you. Have some questions. I love it when patients show up with, a list of questions because it tells me they're engaged. It tells me that they, that we're having this dialogue together and we're coming up with a decision together. So what are your current symptoms? What makes them worse? What brings you here today to talk about that? Communicate effectively. It's great when you can have your support system there to advocate. Is telemedicine an option for you? We're not seeing it as much today as certainly we were last year, but if your myeloma specialist lives in another state, perhaps they want to be able to provide telemedicine. And I think we're certainly a lot more open to that than we were 3 years ago before the pandemic. So shared decision-making, what is all of this talk about shared decision-making? And so it really is recognizing your preference along with the data, along with the healthcare providers' clinical experience, and coming up with this Venn diagram, coming up with that treatment decision based on those three circles. Express your goals, express your preference. And I really think that, I know when people have done that, when I see them, I'm just so thrilled that we have options to treat and to meet your goals, and that you really have a preference. All right, and so we heard, so much information today. Knowledge is power. Use your resources. Certainly the IMF is an amazing resource. They just are there to help you along the way through all of it. You're not alone. This is going to be a very long journey. And so, really look at all of your supports. And I really thank you for listening to me this evening. So we'll open it up to questions.
Well, that was fantastic. I listened to these talks and such with a lot of people, but something just slapped me in the face. It said shared decision making. What people got to understand that there is a decision making process. I just really think you accomplished that in your discussion. Thank you.
Thank you, Kelly.
All right, now we're going to probably let me see if I can get one question in. While we're doing this, go to your question and answer segment on the bar and do Q&A, and let me slide this up and see if anyone's come up. They keep asking about peripheral neuropathy. Let's see this question here. The takeaway from tonight is that multiple myeloma is going to come back. We are under the impression many people live long, healthy lives, 20 years plus today without relapses. What are relapse statistics? Craig, did you talk about that?
I didn't, but I can tell you.
Oh, okay, good.
That, I think in my last slide, and is that myeloma is treatable, but it's not curable yet. And so, how many people, eventually relapse after their initial therapy? The vast majority of patients eventually relapse, and then they go on to second line therapy and then third line therapy. But kind of the hopeful thing is that again, when I had a little bit of hair, we were really stuck after 3 lines. I mean, we were kind of done, where we didn't have any options. And now the number of lines, now we're talking about people that have had 6 lines of therapy, getting CAR T and bispecifics. And so, the number of therapies that sequentially that we use, is constantly being replenished. It's, a constant well of research, that when a patient relapses, today, there are multiple, next lines of therapy that are further down. And the newest therapy, the bispecifics and the CAR Ts, as someone had asked earlier, are already being explored in earlier lines of therapy. And so, as soon as I think, gosh, I wonder if we're done, if we have said good enough, and that never happens. It's never, ever happened as long as I've been doing this. Not a myeloma specialist, doctor, researcher, nurse has ever said enough that we keep on getting new drugs to keep people going. And there's always hope that after you relapse, there is something around the corner that will keep things going.
Well put. Kim, any recommendations to relieve leg or hand cramps?
Yes, there certainly is. And there's a few things that you can do. Number one is to increase the amount of fluid that you're drinking. So if you can really get that up to about 2 or 3 liters a day, or 2 or 3 quarts of fluid a day, that's really very helpful. Magnesium is very helpful. You can take 400 milligrams twice a day, but you're probably going to have some GI side effects. So I often tell people to take one, maybe 250 milligram pill or a 400 milligram pill And then if it doesn't help and you're not having GI side effects, increase that to twice a day. Quinine water, tonic water is certainly another way. One of the physicians that I work with is a real advocate for pickle juice.
Mm-hmm.
Pickle juice, right? Craig is saying, "Yep, he's a fan. He's a fan."
Tonic water.
That's great. David?
Tonic water helps almost everybody because there's quinine in it.
Yeah.
So they need to drink a glass a day. It doesn't work once you have a cramp. You can't wake up in the middle of the night. Most of the cramps happen at night. You can't wake up in the middle of the night and go grab a glass of tonic water once your leg's all cramped up. You have to drink it before you go to bed. So one glass of tonic water, any brand, generic, cheap, doesn't matter, is actually one of the most effective treatments. Back in the day, because I'm older than everyone on the call, from at least the IMF standpoint, you could prescribe quinine to patients, but it's no longer available. But
Not available.
there's a small amount in tonic water. It works for most people.
David, you said you have a big thing coming up. Is that your 65th birthday?
I wish. I've been past Medicare for a while, dude.
I'm impressed you still run and climb and hike and do all that at past Medicare. Listen, everyone, I want to reiterate here that we did go over a little bit, but I need to thank three very special people to me, Craig and David and Kim. I got a little shout out from Robin and Michael Toohey to say hi to you guys too. Y'all have dealt with or spent time with them as well. So thanks for joining us today. As a follow-up to this meeting, you'll get a link that will show you or get you directly to the presentation. And again, as a follow-up, we want you to participate in all surveys. So do so. And I need to thank our sponsors. I forgot about this slide. Abby, Amgen, Bristol Myers Squibb, GSK, Janssen, Carroll Farm, Santa Fe, and Takeda. Craig, David, Kim, thank you so much. Have a great day.
Thank you.